I'm Dr. Madanki from CareIVF, and today I'm going to speak on a very important aspect of fertility issues and management, and that is male infertility. What is infertility? Infertility is the inability of a sexually active, non-contracepting couple to achieve spontaneous pregnancy within 1 year. About 15% of couples do not achieve pregnancy within 1 year and therefore seek medical treatment. 1 in 8 couples encounter such problems when attempting to conceive their first child, and 1 in 6 when attempting to conceive their second child. Infertility affects both men and women. In 50% of involuntary couples, a malefactor is found together with abnormal semen parameters. 1/3 of causes of infertility is due to a malefactor. Male infertility can be due to a variety of reasons, which leads to decreased sperm count or motility or abnormal physical appearance of these sperms, that is abnormal morphology. These can be due to defects at multiple levels, starting from brain signaling pathways, which are called pretesticular, to those of the testis or post-testicular ducts, which transport sperms to the male urethra. It is estimated that in about 50% of men with poor semen quality, no cause can be identified. Let's come to history taking. History taking is a very important aspect of the management. In 30 to 40% of cases, no known male causes can be found, and therefore it is called idiopathic male infertility. Now, these men present with no significant previous history of diseases which may affect fertility and have normal to near normal findings on physical examination, endocrine, genetic and biochemical laboratory parameters. However, semen analysis might reveal some pathological findings in the spermiogram. Idiopathic male infertility, that is the category with unknown causes, has also several factors, including endocrine disruption as a result of environmental pollution, reactive oxygen species, genetic and epigenetic abnormalities. There could also be a history of smoking, chronic diseases like diabetes, liver diseases, tuberculosis, and other intake of drugs can also be a contributory factor. So, this is an important aspect which we derive from a proper history taking. History of chronic illnesses, high fever, typhoid, dengue, malaria, and also high stress can be a contributory factor. Liver diseases like cirrhosis and also diseases like chronic renal failure are important, along with a history of any prior surgery or trauma to the testis in childhood or the growing up years. Any accidents involving the testis may also result in the formation of anti-sperm antibodies. The occupational history of the patient is of prime importance. It is important to note if there is any family history of infertility, especially in the father or any other male relatives from the paternal side. Let's discuss the causes. Causes of testicular deficiency may be congenital or acquired or idiopathic. Here's a table which enlists these causes. Let's come to the diagnostic evaluation. A semen analysis is the first test that is done for evaluation of male infertility. The medical history and the physical examination are also standard assessments in all men, including a semen analysis. A comprehensive and biological examination is indicated if the semen analysis shows abnormalities compared with the reference values, which is guided by the WHO laboratory manual for the examination and processing of human semen. It is the consensus that modern spermatology should follow and adhere to these guidelines. Here is a table which tells us the normal values. Frequency of semen analysis. If the results of the semen analysis are normal, according to the WHO criteria, a single test is sufficient. But if the results are abnormal in at least 2 tests, then we recommend further andrological investigations. Now, it is important to differentiate between the following: oligospermia, number 2 asthenozoospermia, and teratozoospermia. In oligospermia, the spermatozoa count is less than 15 million per ml. In asthenozoospermia, less than 32% progressive motile sperms are seen, and in teratozoospermia, less than 4% of normal forms. It is often seen that these 3 can occur simultaneously, which is then defined as oligo, astheno, teratozoospermia or OAT syndrome. In extreme cases of oligospermia, where the spermatozoa is less than 1 million per ml, there is an increased incidence of obstruction of the male genital tract and associated genetic abnormalities. Azoospermia, for complete absence of sperms in the semen, can also be classified as obstructive or non-obstructive, and which can then be further diagnosed by certain tests done by the andrologist, such as hormone evaluation, ultrasound of the scrotum, and a testicular biopsy. Also, in these patients, a genetic consult with a geneticist is essential, along with karyotyping at the least, to exclude any genetic causes for azoospermia, such as a Klinefelter's syndrome. Let us now discuss the hormonal evaluation. Important chemicals called hormones control the production of sperms in men with testicular deficiency. Hypogonadotropic hypogonadism is usually present with high levels of FSH or follicle stimulating hormone and LH or also called luteinizing hormone, and sometimes low levels of testosterone. An andrologist is usually better equipped to make sense of these values and correlate with the clinical condition of the male partner as well as the semen analysis. Ultrasound and its role. In addition to the physical examination, on a scrotal ultrasound may be helpful in finding signs of obstruction, such as varicocele, enlarged epididymis with cystic lesions or absent vas deferens, and may demonstrate signs of testicular dysgenesis. For patients with low seminal volume and in whom distal obstruction is suspected, transrectal ultrasound or TRUS is essential. Invasive diagnosis including testicular biopsy, scrotal exploration and distal seminal evaluation are indicated in patients with obstructive azoospermia in whom an acquired obstruction of the seminal duct is suspected. What is testicular biopsy? In selected few cases as decided by the andrologist, testicular biopsy may be indicated to exclude spermatogenic failure. Testicular biopsy should be combined with extraction of testicular spermatozoa in an IVF setting. It is called TESI with cryopreservation for future use in IVF or ICSI treatment. Do stay tuned with us for the next videos on types of male infertility.